Today our topic of discussion will be obstructive jaundice. Mainly I will be dealing with the questions which comes in MBBS, third MBBS part 2 final examination. Now question may come like this: what are the causes of obstructive jaundice? How will come at a diagnosis? Describe the clinical feature and diagnosis of choledocholithiasis. Discuss the various options in the management of choledocholithiasis. Now, first causes of obstructive jaundice are biliary atresia, choledochal cyst, CBD stone, chronic pancreatitis, ascending cholangitis, biliary stricture, and parasitic infection or infestations. Among the malignant causes, there are carcinoma head and periampullary region of the pancreas, cholangiocarcinoma, Klatskin tumor, carcinoma at the confluence of hepatic ducts above the level of cystic ducts and is known as Klatskin tumor. Here, they will cause hydrohepatosis without GB enlargement. Extrinsic compression of CBD by lymph nodes or tumors and carcinoma of gallbladder. Now, first we have to take history to differentiate between medical and surgical jaundice. If there is surgical jaundice, how to differentiate between stone disease and malignancy, you should know. Gradual onset of yellowish discoloration of eyes and urine for last 6 months. That is the main history which patient can give you. Itching all over the body. Scratch marks confirm a patient's history of pruritus. Patient is passing clay colored stools since onset of yellowish discoloration of eyes and urine. Anorexia and significant loss of weight over last 6 months. Waxing and waning of jaundice is found in periampullary carcinoma and choledocholithiasis. Melena is present in case of periampullary carcinoma. On examination, on general survey, nutrition is poor, pallor is present and the patient is deeply jaundiced. There is no cervical lymphadenopathy. Then you have to look for supraclavicular lymph node. Abdominal examination, shape and contour of the abdomen should be noted. Umbilicus is normal if there is no ascites, and liver and spleen are usually not palpable. Now coming to the Corvusius law. Now if in a jaundice patient, if the gallbladder is palpable, then it is not due to choledocholithiasis. So it is obviously due to any malignant disease. So in case of cystic enlarged gallbladder with obstructive jaundice, you can come to notice the patient is not having choledocholithiasis, rather he or she may be having any malignant disease. Now, what are the exceptions of Corvusius law? Double impaction of stone, one at common bile duct, another at the cystic duct, primary CBD stone, distended gallbladder due to large stone at head. If a lump is palpable in the right hypochondriac region, extend into the epigastric and right lumbar region, and the lower medial and lateral margins are palpable and the upper margin passes deep to the right costal margin, with a palpable swelling is soft cystic with smooth regular surface, then this is certainly a gallbladder swelling due to periampullary or carcinoma head pancreas. Now come to the second part of the question. That is clinical features. Symptoms. Choledocholithiasis may be asymptomatic. It may be produce sudden toxic cholangitis leading to rapid demise. Biliary colic, jaundice or pancreatitis may be isolated findings or may come in combination with signs of infection. Biliary colic from common duct obstruction cannot be distinguished from that caused by stones in the gallbladder. Pain is felt in the right subcostal region, epigastrium, or even the substernal area. Rayford pain also common. Choledocholithiasis should be strongly suspected if intermittent chills, fever, or jaundice accompanies biliary colic. Some patients notice transient darkening of their urine during an attack, even though jaundice is not evident. Pruritus is usually the result of persistent long-standing obstruction. The itching is more intense in warm weather when the patient perspires and usually worse on the extremities than on the trunk. It is much more common with neoplastic obstruction than with gallstone obstruction. Next, the signs. The patient may be icteric and toxic with high fever. A palpable gallbladder is unusual in patients with obstructive jaundice due to common bile duct stone. Tenderness may be present in the right upper quadrant, but is not often as marked as in acute cholecystitis. And tender hepatic enlargement can also occur. Long-standing ductal infection can produce intrahepatic abscesses. Hepatic failure or secondary biliary cirrhosis may develop in unrelieved obstruction of long duration. Since the obstruction is usually incomplete and intermittent, cirrhosis develops only after several years in untreated disease. Acute pancreatitis, a fairly common complication of calculous biliary disease, rarely a stone in the common bile duct, may erode to the ampulla, results in gallstone ileus. And also hemorrhage in the bile duct is known as hemobilia. Now I will go through very shortly in gallstone ileus. This may come as a short note. So gallstone ileus is an uncommon cause of mechanical bowel obstruction. However, it is associated with high morbidity and mortality and usually affects elderly patients who often had other concomitant medical surgical disease. Pathogenesis. The gallstone ileus is defined as the intestinal impaction of a gallstone passing through a bilioenteric fistula, mainly cholecystoduodenal. There may be other fistulous communications. Probably the responsible process for most fistula formation is due to the impaction of a large stone in the gallbladder causing pressure, ischemia, and necrosis of the wall of it that leads to the development of an inflammatory adhesion between gallbladder and intestine, and then an erosion of gallstone on adjacent structures causing a cholecystoenteric fistula with a subsequent evacuation of the stone to the intestinal tract. The entrance of the small gallstone may also occur by natural passage through the bile duct due to OD sphincter disorder. Usually the gallstone that go into the digestive tract are expelled into the feces, but if the stone size exceeds the diameter of the bowel segment, it could impact and cause obstruction. Most of the obstructive stones are bigger than 2.5 cm diameter. The most gallstones impact the terminal ileum due to its relative minor diameter and persistent activity, followed by jejunum stomach duodenum, which is known as Bourveret syndrome and colon. Incidence usually affects elderly patients between 65 and 75 years of age, higher prevalence in females. Diagnosis. The classical clinical presentation is elderly woman with prior biliary disease that presents episodic subacute intestinal occlusion, that is tumbling obstruction, as a result of continued stone migration. The gallstone impaction produces transient abdominal pain and vomiting disappear when the stone moves in the intestinal lumen and reappears with a new obstruction. Intermittent symptoms may be present several days prior to the medical evaluation. Hematemesis is an association due to bleeding at the site of bilioenteric fistula. It is important to have a high clinical substitution of this entity, being able to suggest it as a preoperative diagnosis based on a plain abdominal film. Other imaging modalities used are ultrasound and CT, being this the most important because it allows a more accurate and early diagnosis that helps in the therapeutic approach. Plain abdominal films finding suspicious of gallstone ileus are demonstration of the classic regular triad pathognomonic of gallstone ileus. It is characterized by air in the biliary tree, signs of partial or complete bowel obstruction, and visualization of a non-ectopic gallstone. Ultrasonography can demonstrate the bilioenteric fistula, residual cholelithiasis, and choledocholithiasis and cholecystitis. Treatment. The main therapeutic goal is to solve the obstruction, mainly through a surgical procedure, enterolithotomy, and stone extraction. A one-stage procedure may be considered in patients at a low surgical risk, consisting in surgical resolution of the obstruction, surgical treatment of bilioenteric fistula, and cholecystectomy. In patients with high surgical risk, most of the patients, the main goal is to treat first the intestinal obstruction. The gallbladder can be removed in a two-stage procedure if there is a recurrence or symptoms of cholecystitis. Bilioenteric fistulas may close or shrink spontaneously, especially if the cystic duct is patent or there are no residual stones. Bowel resection may be needed if there is perforation, ischemia, or a gallstone that cannot be detached. Sometimes the entity may resolve spontaneously. Now coming to the choledocholithiasis part again. So diagnosis, laboratory investigations in cholangitis, there will be leukocytosis of 15,000 per liter and values above 20,000 per liter are common. A rise in serum bilirubin often appears within 24 hours after the onset of symptoms. The absolute level usually remains under 10 mg per deciliter and most are in the range of 2 to 4 mg per deciliter. The direct bilirubin exceeds the indirect. Fluctuating jaundice is so characteristic of choledocholithiasis that it fairly reliably differentiates between the benign and malignant obstruction. The serum alkaline phosphatase level usually rises and may be the only clinical abnormality in patients without jaundice. When the obstruction is relieved, the alkaline phosphatase and bilirubin level should return to normal within 1 to 2 weeks. Mild increase in AST and LT are often seen. AST level usually transiently reach 1000 units. Amylase and lipase have to be documented if there is pancreatitis. P time and INR should be less than 1.5. Ultrasound can document stones in the gallbladder and estimate the diameter of the common bile duct. A dilated bile duct more than 8 mm in diameter on ultrasonography in a patient with gallstones, jaundice, and biliary pain is highly suggestive of having choledocholithiasis. As stones in the distal bile duct slowly move down, bowel gas can preclude their visibility on ultrasound. The prevalence of choledocholithiasis is significantly higher in the setting of a dilated common bile duct than in patients with a non-dilated duct. MRCP provides excellent anatomic detail with sensitivity and specificity of 95 and 98% respectively. It avoids the need for invasive ERCP in more than 50% patients. It can be used as screening test for patients at low or moderate risk for developing common bile duct stones before ERCP. Now, ERCP, it is a diagnostic and potentially therapeutic test of choice for patients with suspected common bile duct stones. Cannulations of the ampulla of Vater and diagnostic cholangiography are achieved in more than 90% of cases. Minimal morbidity rates of less than 5% and now there. US endoscopic ultrasound can also be used to identify bile duct stones without cannulation of the ampulla and it's associated with risk, but less sensitive than ERCP. The management. First, general measures. Patients should be hydrated and give proper nutrition. Third generation cephalosporin or ciprofloxacin should be given either orally or IV. Injection vitamin K 10 mg IM once daily for 3 consecutive days. If INR is deranged, give FFP. Definitive treatment. So first we should go for minimally invasive procedures like endoscopic cholangiography. The use of endoscopic cholangiography in patients with suspected common bile duct stones not only confirms the diagnosis but also provides ductal clearance of the stones and sphincterotomy before subsequent laparoscopic cholecystectomy. Patients with worsening cholangitis, ampullary stone impaction, biliary pancreatitis, multiple comorbidities, and cirrhosis are considered as good candidates for preoperative endoscopic therapy. After endoscopic sphincterotomy and stone extraction, patients with gallstones still remain at high risk for developing future biliary complications. Therefore, prompt cholecystectomy after endoscopic clearance of the common bile duct should be performed during the hospital admission if the patient is fit for surgery. Endoscopic sphincterotomy is unlikely to be successful if patients have large stones that is more than 2 cm and it is contraindicated in the presence of stenosis of the bile duct proximal to the sphincter. Laparotomy and common duct exploration are required in a few cases. Laparoscopic common bile duct exploration is an intraoperative cholangiogram is present at the time of cholecystectomy. It will also document the presence of common bile duct stone during and after the procedure. Laparoscopic common bile duct exploration through the cystic duct or with formal choledochotomy allows the stones to be retrieved during the same procedure. Now coming to the open surgery. Open common bile exploration with the increased use of endoscopic percutaneous and laparoscopic techniques, open common bile duct exploration is rarely performed today, though it should be performed when a concomitant biliary drainage procedure is indicated. Open common bile duct exploration is associated with low operative mortality and morbidity. The rate of retained common bile duct stone using intraoperative cholecystectomy is less than 5%. Stones impacted in the ampulla of Vater may be difficult for both endoscopic ductal clearance and due to common bile duct exploration. In these cases, transduodenal sphincteroplasty and stone extraction should be performed. If this is not successful, choledochoduodeostomy or a Roux-en-Y choledochoduodeostomy should be performed. If the CBD is not dilated and expertise for choledochoduodeostomy is lacking, T-tube drainage should be done. Transduodenal sphincterostomy is useful in the management of choledocholithiasis when there is stone in the impact in the ampulla of Vater, papillary stenosis, and multiple stones, particularly in the presence of a non-dilated bile duct. Choledochoduodeostomy is indicated in patients with recurrent stones requiring repetitive interventions, impacted or giant stones, biliary sludge, and ampullary stenosis. A common bile duct diameter of at least 1.2 cm is important in assessing the feasibility of common CDD because this allows a wide enough stoma to ensure good biliary drainage and avoid stenosis. Now coming to the second question, a 60-year-old man presenting with palpable lump in right hypochondrium with eolo discoloration of eyes What is your diagnosis? Discuss the etiopathogenesis, investigations, and management of this case. Here, the most likely diagnosis is carcinoma of head of pancreas. Etiopathogenesis. Pancreatic cancers can arise from the exocrine and endocrine portion of the pancreas, but 93% of them develop from the exocrine portion, including the ductal epithelium, acinar cells, connective tissue, and lymphatic tissue. Approximately 75% of all pancreatic carcinomas occur within the head or neck of the pancreas, 15 to 20% occur in the body of the pancreas, and 5 to 10% occur in the tail. Tobacco smoking is the most common recognized risk factors for pancreatic cancer. Others include obesity, high alcohol consumption, history of pancreatitis, and diabetes, family history of pancreatic cancer, and possibly selected dietary factors. Only 5 to 10% are hereditary in nature. Because there is excess risk for pancreatic cancer is better in patients recently diagnosed with diabetic mellitus, it has been suggested that diabetes may be at least in a part or a consequence for the early manifestation of pancreatic cancer. Less than 5% of all pancreatic cancers are related to underlying chronic pancreatitis. Alcohol consumption does not appear to be an independent risk factor to pancreatic cancer, but it can lead to chronic pancreatitis. Risk factors are smoking, obesity, consumption of red meat, especially of the processed kinds. Diabetes mellitus, numerous studies have examined the relative risk. Chronic pancreatitis, long-standing chronic pancreatitis is also a substantial risk factor. Genetic factors. Approximately 5 to 10% of patients with pancreatic carcinoma have some genetic predisposition to developing the disease. Now, among the genetic factors, 8 to 95% of patients have mutations in the KRAS2 gene. 85% to 98% of mutations, deletions or hypermethylation in the CKD-N2 gene. 50% of mutations in P53. 55% of homozygous deletions or mutations in SMAD4. Some of these mutations can also be found in high-risk precursors of pancreatic cancer. Families with BRCA2 mutations, which are associated with a high risk of breast cancer, also have an excess of pancreatic cancer. The inherited disorders that have increased the risk of pancreatic cancers include hereditary pancreatitis, multiple endocrine neoplasia, hereditary non-polyposis rectal cancer, familial adenomatous polyposis, Gardner syndrome, familial atypical multiple mole melanoma syndrome, von Hippel-Lindau syndrome, germline mutations in the BRCA1 and BRCA2 genes. Pancreatic cancers arise predominantly from ductal epithelial cells of the exocrine pancreas and of the ductal adenocarcinoma histological subtype. Now, this PDAC is an aggressive disease associated with poor clinical prognosis, weakly effective therapeutic options, and a lack of early detection methods. Furthermore, the genetic and phenotypic heterogeneity of PDAC complicates efforts to identify universally efficacious therapies. PDACs commonly harbor activating mutations in the KRAS oncogenes, which is a potent driver of tumor initiation and maintenance. Inactivating mutations in tumor suppression genes such as CDKN2A by P16, PT53, and SMAD4 cooperate with KRAS mutations to cause aggressive PDAC tumor growth. PDAC can be classified into 3 to 4 molecular subtypes by global gene expressing profiling. These subtypes can be distinguished by distinct molecular and phenotypic characteristics. Signs and symptoms of pancreatic cancers. Frequent signs are weight loss, pain, jaundice, dark urine, light stool, anorexia. In case of pancreatic body or tail cancers, weight loss, pain, weakness, nausea, anorexia, and vomiting are there. There are also some infrequent symptoms also. Now coming to the most important part, that is management of carcinoma of head of pancreas. Now for investigation, blood test. Patients with pancreatic head lesions frequently have elevated bilirubin and alkaline phosphatase levels suggestive of obstructive jaundice. Other routine laboratory studies are usually normal. Hemoglobin may be low. The two most widely used pancreatic cancer serum markers are the CEA and the Lewis blood group antigen CA19/9. Both are frequently elevated in patients with advanced disease. Extremely high levels of either CA19/9 or CEA usually indicate unresectable or metastatic disease. Coming to the imaging studies, the main imaging modalities used for patients with suspected pancreatic neoplasms include right upper quadrant ultrasonography, CT scan, MRI with or without MRCP, endoscopic retrograde cholangiopancreatography, and percutaneous transhepatic cholangiography. Right upper quadrant arterioscopy is the commonly the initial test. It can detect gallstones, dilatation of biliary tree, and pericholecystic fluid. This imaging modality can also pick up hepatic metastasis, pancreatic masses, peripancreatic and hilar lymphatic and ascites. The investigation of choice in the work of patients suspected of a pancreatic cancer is a multi-director spiral CT and is probably the single most useful diagnostic and imaging and staging modality. CT provides more complete and accurate imaging of the pancreatic and surrounding structures. It gives very important information about the immediately adjacent vascular structures such as the portal, superior mesenteric and splenic veins, as well as the superior mesenteric artery and celiac axis. The involvement of periampular lymph nodes and retrobudal structures may be demonstrated. Additionally, information about distant metastatic disease can be gleaned if metastatic deposits are seen in the liver or in the peritoneal cavity. The presence of ascites is usually an ominous sign. MRCP is now being utilized to image the biliary tree and the pancreatic duct. It has the advantage of being completely non-invasive. The vascular structures can also be visualized with the use of the contrast agent gadolinium and the performance of a magnetic resonance angiogram. Thus, a single session in a scanner can provide information about tumor size and extent, the introductory anatomy of the biliary and pancreatic system, and the status of the nearby vasculature. The resulting scan has the potential to provide information about tumor size and extent, biliary and pancreatic ductal anatomy, and vascular involvement through a single non-invasive procedure. ERCP sometimes is required to solidify the diagnosis of pancreatic cancer. The classic findings of a long irregular stricture in a pancreatic duct with distal dilatation of double duct sign, in which there is cutoff of both the pancreatic duct and distal bile duct at the level of the genu of the pancreatic duct at pathognomony. ERCP may be of benefit in patients with biliary obstruction and cholangitis, whereupon an endoscopic stent can be placed for decompression. ERCP is most useful when there is pancreatic duct obstruction, but no mass is evident on either CT or MRI. In this situation, it is necessary to try to distinguish chronic pancreatitis from pancreatic cancer. US is the most common imaging procedure used to diagnose pancreatic cancer. It is often the best procedure to obtain samples of a tumor to make the definite diagnosis of pancreatic cancer. EUS may be able to find small pancreatic masses that have not been detected by computed tomography or MRI, but suspected by the doctor as a result of symptoms and or blood test. Studies show that EUS is equal to or better than CT scans for detection of early pancreatic cancer. Biopsy to confirm the presence and identify the type of cancer is usually required before chemoradiation therapy of unresectable tumor. Percutaneous biopsy performed with either CT or image ultrasound guidance or translational biopsy performed with endoscopic ultrasound guidance is routinely employed in these situations. Treatment and prognosis. Most tumors are not resectable at diagnosis. Surgery for stage 1 and 2 does offer the chance of cure with, however, high morbidity and mortality. Resection is performed with a Hupel's operation. Even when resection is possible, the majority of patients succumb to recurrence with only a doubling of survival in the operated patients from 5 to 10% at 5 years. Almost a quarter of patients are dead 12 months following diagnosis. Palliative non-surgical treatment of pancreatic cancers. Establishing the diagnosis and relieving symptoms of jaundice, gastric obstruction, and pain are the goals of palliative non-surgical treatment. Tissue diagnosis can usually be made by CT or ultrasound guided percutaneous fine needle aspiration of either the tumor or its metastasis. Transduodenal fine needle aspiration of the tumor with endoscopic ultrasound guidance and duct cytology obtained by brushing is an alternative method of establishing the diagnosis. Decompression of the obstructed biliary tract can be achieved using either an endoscopic or a percutaneous transhepatic approach. Pancreatic tumors can extend into and obstruct the duodenum, leading to gastric outlet obstruction. This commonly occurs in the second portion of the duodenum in patients with pancreatic head cancers. Pancreatic body tumors can invade the third or fourth portion of the duodenum and also cause obstruction. Many of these patients can be palliated by endoscopic placement of expandable endoluminal metallic stents into the duodenum. Pain, which is a common symptom of pancreatic cancer, is usually caused by tumor invasion of the peripancreatic neural plexus. Most patients can be adequately treated with orally or transcutaneously administered analgesics. Narcotic medications may be required when or if this fails. Percutaneous CT guided or endoscopic ultrasound guided celiac plexus block may be helpful. palliative management of surgical palliative surgical management of pancreatic cancer. Most of the symptoms experienced by patients with unresectable pancreatic cancer can be relieved by non-surgical means. Surgical palliation is for the most part employed for patients who are undergoing laparotomy for anticipated resectable disease and found to be unresectable at the time of surgery. In this situation, biliary tract decomposition can be done by creating either a cholecystectomy genostomy or portocogenostomy. Dural obstruction can be managed by creation of a side-to-side gastrogenostomy in which an anticolic jejunal loop is anastomosed to the posterior of the gastric antrum. Palliation of pain can be achieved intraoperatively by injecting alcohol in the celiac plexus, and some surgeons routinely perform operative celiac plexus block at the time of surgical palliation. However, many patients with unresectable pancreatic cancer can be successfully managed with minimal or no narcotic analgesics, and when more severe pain occurs, results similar to those achieved by intraoperative chemical splanchnicectomy can be used using a percutaneous approach. Chemoradiation therapy. Many different protocols for chemoradiation treatment of recurrent or unresectable pancreatic cancer have been described. The best results have been achieved using radiation therapy combined with either 5-fluorouracil or gemcitabine. Now coming to the last topic of today's session, preoperative preparation of a case of obstructive jaundice. Proper diagnosis and assessment, injection of vitamin K, IM 10 mg for 5 days, fresh frozen plasma often requires 6 bottles or more, blood transfusion in case of anemia, oral neomycin, lactulose, mannitol, 100 to 200 ml BD IV to prevent hepatorenal syndrome, hydration, repeated monitoring by doing prothrombin time, electrolytes, antibiotics like third generation cephalosporins, and calcium supplements as calcium chloride. So this completes today's lecture. Now this is a part of the chapter I have discussed. Now you can have the PDF of all the question answers of MBBS, third MBBS part 2, which has come in West Bengal Health University exam, in a PDF which will be shared in my website. You can collect it or download it. I think within 2 to 3 days, both the PPTs and PDFs will be uploaded in the website, that is orcosearch.com. You can have a go at it and can be downloaded from that link. Thank you.